Hello, my name's Rebecca Elwell and I'm the Macmillan Lymphedema Advanced Nurse Practitioner at the Royal Stoke University Hospital and a very proud trustee of the British Lymphology Society. Welcome to the British Lymphology Society's Lymphedema Awareness Week, and this presentation is entitled Recognising Red Legs Syndrome and What to Do About It. So the aims of the webinar are to provide a step-by-step approach to support clinical decision-making and the ability to recognise and effectively manage red legs, to provide key principles for practice, information to aid prompt and effective treatment, and a platform generally to raise awareness of red legs. Redness of the lower legs is common in many conditions but is often mistaken for cellulitis. Misdiagnosis means that patients don't get the treatment and support that they need, and they may be overtreated with antibiotics. Redness throughout both legs, usually below the knee, with no tracking redness above the knee or any change in redness, with associated warmth and tenderness, no raised temperature and generally feeling the same as usual, and the redness being caused by chronic inflammation, underlying problems with the skin and or veins which will not respond to antibiotic therapy, can be assumed as red legs. A recent study in 2020 reported that 30% of patients are misdiagnosed with cellulitis, and with antimicrobial resistance and stewardship uppermost in the minds of clinicians, along with appropriate use of finite resources and a desire to get it right first time to improve patient experience, there has never been a better time to raise awareness of red legs. Cellulitis is a bacterial infection of the skin and subcutaneous tissues which causes fever, high temperature, and one to feel extremely unwell. It is acute, rapid onset, with painful redness, often on one lower limb but can be anywhere on the body. There may be warmth and tenderness with or without skin blistering. Blood tests may confirm infection is present, and there may be a port of entry into the skin, for example, athlete's foot or a scratch. There is a strong link with lymphedema. Cellulitis requires prompt treatment with antibiotics, and for some this will need to be intravenous or into the vein. If you believe that you have cellulitis, you must seek medical advice from either your GP, walk-in centre, 111 or A&E if you are acutely unwell. If you have one leg that is red, hot, swollen and painful, it's also really important to exclude deep vein thrombosis or a clot in the leg. Many people are told that they have cellulitis and treated with antibiotics, but there is little or no improvement in the symptoms. In this instance, it's likely that the redness is not caused by bacteria or an infection, but is inflammation, and however many antibiotics are given, the symptoms will not improve. If you have redness in both legs and have been treated with antibiotics with no improvement, this session is for you. To learn more about cellulitis, patron of BLS, Professor Vaughan Keeley, is providing a webinar on cellulitis as part of BLS Awareness Week, which will be available on Facebook and YouTube. The British Lymphology Society and the Lymphedema Support Network consensus document on the management of cellulitis in individuals with lymphedema is pictured here and can be found at www.thebls.com. Red leg syndrome includes bilateral lower limb redness, pain, discomfort, heat and skin changes, but the patient is usually apyrexial with no temperature and does not have systemic malaise. The symptoms of red legs are misery. Having red legs is very, very miserable and affects quality of life. Pain, including tenderness, burning and throbbing. Skin sensitivity, where the skin may appear thin and shiny, and which can be made worse by the use of some management strategies, including steroid cream. It may be sensitive to knocks. There would be a fear of ulceration and thus skin breakdown. An intense feeling of heat or burning, like you cannot stand anything on the legs, even bedclothes, and many people stop wearing socks or tights. That is if you're lucky to be able to get socks or tights to fit, as many people with lymphedema or swelling can't. Some people will use cold compresses or plant sprays to try and calm the legs, and some find that moisturising creams seem to make the redness worse or feed it. If edema is present, a sensation of bursting, an increased risk of leakage of lymph through the skin that we call lymphorrhea may also be a factor. The risk factors for developing red legs include increased age and frailty, chronic venous insufficiency, reduced or poor mobility, lymphedema and chronic edema, obesity, and chronic conditions like eczema or psoriasis. The British Lymphology Society Red Leg Pathway is easy to follow in a flow diagram format. It covers both unilateral and bilateral causes of red legs. Its aim is to assist differential diagnosis and provide practical management strategies both for and in the absence of lymphorrhea. It covers failure to respond and atypical cases, and BLS is proud to say that it is endorsed by the Legs Matter campaign. It can be found free to download at www.theblscop.com and is in an electronic format, giving more information on various conditions as you click through them. Of lower limb redness is lipodermatosclerosis. This can be extremely painful, especially at the onset when the skin and tissues are shrinking and drawing in. The skin appears inflamed, red, hot and tender. One leg can be worse or can start ahead of the other. In chronic cases, there may be dull redness, normal skin temperature and little or no pain, and swelling can also be problematic. In the text, it's often referred to as inverted champagne bottle legs, like the narrowing of the neck of the bottle at the lower end of the extremity, and there can be associated hemosiderin staining, a brown pigmentation on the skin. Another common cause of red legs is varicose eczema or gravitational dermatitis, which is caused by increased pressure in the leg veins. When the small valves in the veins fail, venous reflux is seen, which can cause fluid to leak into the surrounding tissues. This may be as a result of the immune system reacting to the fluid. The skin can be itchy, red, swollen, dry and scaly. There may be no warmth, but associated staining, spider or telangiectasia thread veins, lipodermatosclerosis, and evidence of healed leg ulceration or atrophy blank. Contact dermatitis is a type of eczema that occurs as a result of contact with a particular substance. It can lead to blisters and appears similar to other types of eczema, being red, itchy and dry. Scratching can result in broken skin and infection can occur, hence the importance of moisturisation with a bland, fragrance-free emollient to reduce the risk of allergy. And if contact dermatitis is suspected, referral on to a dermatologist for patch testing may be necessary. Fungal infections can also cause redness in the lower limbs, but as previously stated, they can also cause cellulitis. So the difference is between whether an acute infection is present, which would most likely be unilateral or one leg, and red legs, which will be both legs. It's a contagious fungal infection that occurs between the toes or on the sole of the foot, causing severe itching, dryness, redness, and there can be blistering. Often there is cracked or soggy skin in between the toes. Intertrigo is a fungal infection in skin folds, which are often seen in patients with very large limbs or obesity, and again this can contribute to redness in the lower limbs. There is also heat-induced redness from hot sources, including radiators, the sun, open fires and hot water bottles, and some of the demarcation lines can be seen here from clothing and shoes. White bias in education has been identified, and a lack of knowledge of assessment and diagnosis in dark skin tones. Redness, which may differ in presentation depending on skin tone, means that individuals with darker skin tones may not receive accurate diagnosis and care, and there are a number of resources now to aid assessing darkly pigmented skin. The management of red legs is split into drug therapy, skincare, compression, exercise, positioning and healthy eating. For drug therapy, if there is itching, antihistamines can be considered. These may help to reduce the itching, and also some creams have an anti-itch agent, for example E45 itch relief cream or Balneum Plus. Taking prescribed pain relief or using over-the-counter simple products is advisable, and reviewing edema-inducing medication such as calcium channel blockers can be really important as part of pharmacological management. Skincare should include washing and drying of the affected areas daily using a soap substitute or a cream for washing in, and then patting dry if the legs are sore, making sure to moisturise with a bland cream or an ointment, and drying carefully in between the toes. Steroid creams can be useful, but they need to be prescribed, used for short periods as directed, as they can thin the skin, and there is evidence to show they can cause redness after stopping their use. If using moisturiser, then apply the moisturiser, wait 30 minutes before applying the steroid. Treating any underlying skin conditions is of paramount importance, particularly fungal infections. Compression gives pain and symptom relief. It is the main part of treatment in red legs. There may need to be consideration given to donning and doffing of the garments. Also, to those who feel that they cannot stand anything on their lower limbs to start with, it may be necessary to titrate compression from a silk stocking or liner, then a compression stocking over. If there is difficulty with donning and doffing, a wrap or stocking with Velcro fastening may ease the application and removal. If lymphorrhea is present, bandaging will be the treatment of choice. Exercise should be proactive and encouraged wherever possible. This should include walking or chair-based exercises in the absence of this ability. For more information and great resources on how to get active with lymphedema, check out the British Lymphology Society's Everybody Can campaign at www.thebls.com. Positioning is hugely important, again, especially where there is lymphorrhea or leakage of lymph. Going to bed at night is really important, using footstools or recliner chairs, and promoting comfort. Healthy eating, maintaining a healthy body weight can really help, and we know that obesity is a causatory factor of the in red leg syndrome. It may be necessary to advise losing weight or involve dietitians and the bariatric team as appropriate. Onward referral should always be considered, including referral onto vascular or dermatology if concerns. In conclusion, the British Lymphology Society Red Legs Pathway is designed to address the importance of differential diagnosis in red leg syndrome, promote early intervention to avoid complications, for example wound development, provide guidance and clarification for management in the presence of lymphorrhea, and to improve patient experience. The British Lymphology Society Lymphedema Awareness Week 2023 website page will stay the same as the current law website page at www.thebls.com/pages/law, and there is a link to the Linktree page, which you may also find useful, which will have a link to register for other webinars and law. If you have both legs that are red, remember redness may be harder to see in darker skin, but you know your legs best. If you've tried antibiotics without success and do not feel you are getting the help you need, it's time to take charge. You have the power. Become a friend of the British Lymphology Society free of charge and receive regular updates, global emails and quarterly e-newsletters. The best way to keep up to date with all clinical resources and information is to visit www.thebls.com/membership/friends-of-BLS. We really hope that you will find the British Lymphology Society Red Leg Pathway to be a practical guide to assist decision making, and if you have red legs, I hope that this information has been helpful. I look forward to your questions. Thank you.
Hello, everybody. Hey. Can you hear me? No?
Yeah.
Oh, sorry, I had a little whirling wheel. So welcome, everybody, and thank you for coming along to day 3 of Lymphedema Awareness Week. It's been a busy week so far. We've had some wonderful sessions already earlier this week from our patrons, Dr. Christiana Gordon and Professor Vaughan Keeley. So as Becky mentioned in the presentation, no time to even sign up retrospectively for some of those sessions. And I'll announce some of the future sessions at the end of the session. And in April, we will hope to have some of that content also available through YouTube to be able to go back and revisit. So thank you very much, Becky. Thank you. Excellent presentation today. There's very few questions in the chat at the moment, so I would just encourage if anybody that's on signed up, if you could just keep adding to the chat, and we may go through some questions that have arisen out of the presentation. And I'm going to hand over to Anna to kick this off with some questions to Becky.
Thanks, Kat. So yeah, we've got a few questions coming through, so I'll try and sort of work through them and sort of amalgamate any that are coming through similar. So one of the first ones we've got, Becky, how will I know what is best for dry skin, cream or ointment, and how do they work on the skin?
I mean, I think I feel a bit of a fraud answering that, Anna, with your dermatology background. We had a half day with our conference with the British Association of Dermatology and the British Dermatological Nursing Group. So really, my answer will not be as an expert, it will be as a lymphedema therapist. And Anna and Kat, if you've anything to add to this, then please do. But generally, what we'll say is use an ointment as it's greasier for those patients with extremely dry skin, and double up with that as a soap substitute as well as a moisturizer. The creams and particularly lotions evaporate much more quickly from the surface of the skin with the warmth, so you lose some of their emollient value. But creams generally are enough for people with non-problematic skin, but ointments where there is more skin change or more significant scaling or dryness. So that's the way that we work, and always avoiding the use of soaps or astringents.
And
yeah, I'd probably just add in there, Becky, that obviously the ointments generally have less potential allergens in them as well, so less likely to cause a reaction.
So I would say that, but I'm going to just throw a spanner in the works there. So if when patients are in garments, sometimes the ointments are quite greasy and kind of can degrade. So again, when the skin's very, very dry, ointments, but you may step down to an emollient or a cream base later on, depending on the skin. And obviously there are ways to mitigate against if an ointment's needed. You may just need an additional liner to be able to kind of preserve the garment's integrity as well. Yeah.
Absolutely agree. Yeah.
Okay. So we've got a question there from Margaret. So people asking if red legs or redness will only affect the lower limbs. So can we transfer this to upper limbs as well?
So the presentation of redness here is bilateral lower limbs, so below the knee redness that's non-spreading, and this is caused by dermatological and vascular conditions in the main part. Any upper limb redness, which would primarily be unilateral, would raise alarm bells that there may be some infection present, or another cause, maybe vascular congestion, or maybe need to screen for axillary vein thrombosis. Redness in the thighs generally is not common, and if it was one-sided, again, that unilateral part would be raising our awareness of a potential acute problem like infection or obstruction. So no, this is relating purely to the lower legs, so below the knee, and bilateral symptoms.
Thanks, Becky.
There's quite an interesting question in there, Becky, as well, which was, does cellulitis always have like a kind of acute systemic manifestation such as fever, or does that come a little bit later?
It's a really interesting one, and anyone who hasn't read the British Lymphology Society consensus document and guidelines for management of cellulitis and lymphedema, I would really urge you to do so, because it does cover in there that the presentation of cellulitis in those with lymphedema may be very different to cellulitis in the absence of swelling. So sometimes patients are do not have a fever, they're apyrexial, they can sometimes feel okay in themselves, and the redness can be more of a rash than a spreading block colour that we think of more traditionally with cellulitis. So I think it's really important that we recognise that cellulitis can be quite different in the presence of lymphedema.
Thanks, Becky.
Okay. Actually, the next question coming through, I think we were all sort of interested in this one as well, that you mentioned the resources for aiding the diagnosis with dark skin. Is there some reference to these?
So there's an excellent paper by Wounds UK about different skin tones, which brought together a number of different groups who'd already done some work, particularly based on the Mind the Gap work. So again, if you haven't seen that, I would urge you to look at that. And I think the importance of listening to patients can't be stressed enough. You know, patients know their own skin, they know the colour. Sometimes redness in a darker skin tone looks more purplish or more discoloured. And again, that can raise some concerns around venous congestion or other changes, but any skin change that the patient reports is good enough for us to investigate and look into. And if it is symmetrical and bilateral, then we may be considering some of the differential diagnosis within the red leg pathway. I think there is some move towards us changing the terminology, and certainly have had some meetings with the National Wound Care Strategy and other groups as to how we move forward with a change that reflects the highlights, the alerts, the symptoms that we want to look out for. But as yet, that's early work stages.
I mean, I'll just maybe add to that, Becky, because we've had a kind of a conversation. I think it's difficult because also within white skin, it may present as red, faded brown, a purpley tinge. In black or darker skin, it may be a variance as well. And it's so varied that we just don't know what the appropriate term to kind of encompass and be more reflective, you know. So if actually anyone has got any suggestions, I'd certainly welcome that in the chat. I don't think there's been an easy answer on what you would call the pathway, is there, moving forward? No.
Okay. And actually just going on there from, you were talking about the red leg pathway. Someone's asked the question, how's that been received by GPs?
So we've been lucky to work with GPs in the development of the pathway locally. So the National British Lymphology Society pathway is based on our local University Hospital of North Midlands pathway. So we worked with GPs in the development of that, and it's been very well received locally. Certainly has helped us manage to get a number of patients into compression hosiery, which primarily they wouldn't have done beforehand. It would have been a referral to the service before those patients moved into compression. So that's really helped alleviate their symptoms sooner. We have GP members of BLS who are able to help us disseminate the information, and also the documents are joint promoted, the red leg pathway within the cellulitis guidelines and vice versa, so that hopefully we are getting people thinking about that differential diagnosis early. So positive responses, but we haven't specifically presented it to the Royal College. Maybe that's something for us to do.
Yeah, no, that would be good to get that out there. The more people that are aware of it, the better, isn't it? It's good. Okay, so just working through some of the other questions. So someone's asked, I was curious regarding skin breakdown. If you have a unilateral skin breakdown, would this still be red legs rather than cellulitis?
So again, that's a difficult one because it is based on the red legs pathway. So we are thinking about a bilateral pathway. So that is more difficult. I think broken skin has the potential for localized infection within that area rather than a necessarily a spreading systemic infection. So wound swabs would be part of the wound management protocol, and the patient would need to move forward with appropriate wound management and referral on if they weren't improving. I know there's a number of lymphedema services that don't accept patients with wounds as well, so there is an element of assessment there that's needed. But the red legs pathway is primarily applicable for patients with bilateral lower limb redness, and if there is unilateral lower limb redness, we need to exclude any acute causes, and within broken skin there could very well be an infection present.
And I might just add to that, Becky, I mean, really what we're talking about here is a warning sign of unmanaged oedema. What comes next is the leaking and the erosions, again, unmanaged. So in the earlier stages of unmanaged, you'll have that redness presenting. And it kind of links to another question here where we're talking about a patient whose thighs are leaking lymphuria, which is quite unusual, actually. And obviously this is extensive edema. It may, you know, there may need to be another holistic assessment. This is obviously unmanaged swelling and probably quite severe. Yeah.
Yes, there could be associated redness with the lymphuria itself, so that the lymphuria can be almost altered pH that can sort of burn the skin, stain the skin red. So again, washing away that fluid is really important for skin hygiene, and then using appropriate emollients. It's really difficult when the thighs swell. We quite often see lymphorrhea to the inner thighs, to the area that is just above the knee, especially where there's been lower limb treatment and then nothing above. So the fluid has been moved into those areas, and particularly, as you said, Kat, in complex swelling and large misshapen limbs. And again, bandaging above the knee is not usual training for the vast majority of our community colleagues, so it's very difficult to manage. And the standard approach may be something that needs complete revision and teamwork in order to improve that for that individual patient.
Yeah, brilliant. It's just a question here, Becky, about where we would get the silk liners from.
Yeah, silk liners are really not favoured by the prescribing authorities. So there's been a lot of information out there around the not prescribing of these items. So that is problematic. We do still ask our GPs, and through the DACs that we use, so things like patient choice, day long. So we do still ask for these silk garments. And I would say we're successful in probably about 50% of cases. And we've written some justification as to why patients should have them and why they find them useful. The information that supports the prescribing authorities says that it shouldn't be standard practice, but you could use them. And we've actually successfully used the BLS Red Legs pathway to support their use. So again, that might help if you're trying to get hold of these items for people. So they are available on prescription. Patients can self-fund them, and where necessary, they have done. They're not massively cost prohibitive, about £25 a pair of below knee stockings, and also some services do have the opportunity to purchase items and then provide those to the patient. Some people have their own stock or their own budget, so I would say it's still worth looking into, and I know there are some difficulties with getting them prescribed, but more than happy to share our justification if that would help anyone.
Brilliant. Just starting on from that, is there any are there any particular stockings that you'd recommend, or do you generally suggest we would go for a wrap with red legs? No,
we tend to use compression hosiery in the first instance wherever possible, given the fact that it's much more cost effective, and generally can be obtained by patients in a relatively easy fashion, such as before, like patient choice and day long. So we would tend to use compression hosiery in the first instance. Not all patients with red legs, as Kat said, hopefully it's a warning sign, an inflammatory sign. So not all of them have got extensive lymphedema. It could be that they have mild swelling. So off-the-shelf garments in the main part may be considered first, then made to measure compression hosiery, if not, particularly using flat knits if there is swelling present. So we would not use wraps as a first step, but of course they have their place. There's still limited evidence to support their use. We're waiting for further trials. There's been a 6th trial, but I do feel that they have a place. I think it certainly helps patients who find getting compression garments on and off difficult, but we should exhaust application aids first, because again, we do have a responsibility to be cost effective and use resources wisely.
Yeah, and I guess there's that usefulness. Sometimes if there's a little bit of leakage, it's sometimes, you can continue with a wrap with a small dressing underneath if the leakage will allow. So
yeah, or a stocking with Velcro fastening, if that's what you're looking for. Yeah, lots and lots of options. There isn't one that's right for everyone. It'll always be an individual assessment.
There's an interesting question here, Becky. It's quite broad, so I am going to just slightly alter it. So the question was, what is the best treatment for severe eczema in all types of skin? But I'm going to sort of just reframe that as, what is the best type of treatment for severe eczema on the lower limbs?
So again, it would be dependent on what type of eczema. So again, I feel a fraud answering this with Anna with a dermatology background, so I'm hoping she's going to chip in. But certainly if the patient's got atopic eczema, then you would be wanting to involve dermatology colleagues. This is something that you would need assistance with, and that they should have the very best treatment, and that should be by involving the MDT. If it's varicose eczema, then again, we know that the primary treatment for that is getting your compression right. So although skin hygiene, skin moisturization is hugely important, the compression will be the bit that will move that forward. So it is about your differential diagnosis of the eczema itself. And if you're not sure, then you need to involve your dermatology colleagues, get a referral via the GP to make sure that's right. Some patients will need to undergo skin testing to again ascertain exactly what is causing that. And so many things look like eczema, and so many rashes are eczematous that it can be more difficult. So I would say that we shouldn't be treating patients with bilateral lower limb eczema without assigning what type of eczema that is, and then the management will depend on what that is. So MDT involvement, very important.
Yeah, I would agree with that, sort of getting sort of a clear diagnosis, being sure what you're treating. I know some areas will have their own formularies about what they will use. And again, we'll often go for an ointment rather than a cream because there's less preservatives in it and they'll be absorbed better. And sometimes it's just using that short, sharp blast of steroids rather than just sort of a very sort of weak steroid over a long time. So just making sure it's used appropriate as, you know, as your local guidelines.
And I would totally agree.
And the pathway, the Redlegs pathway does refer to that as well, doesn't it? And then stepping it down to reduce dose, but after that short, sharp shock. Sorry, Kat, you were going to say.
Yeah, no, I was just going to say, no, I concur with both of you. I think just where I'd reframed it to the lower limb eczema, obviously there's just a big link with the varicose eczema and the red legs, the kind of venous congestion that you see. I would say certainly in my clinical practice, it's the largest cohort that I see with that kind of congestion in the lower limb, and that there is a high incidence of varicose eczema alongside that. And again, that leg is screaming out for skincare, steroid perhaps, and just good old compression, really.
Yeah, I would agree, and I think people forget that the compression is the key to a lot of it, and actually getting that right in the first place. Yeah, brilliant. I think there was another more sort of clinical question, which I guess we could lead on from that, where someone's asked that they've developed very itchy skin and blisters on one of their feet. They've already seen a dermatologist and a podiatrist, but they don't have a diagnosis. Could it be eczema athlete's foot? Obviously, they both require different treatments, and what would we suggest?
Yeah, again, I think it is really difficult when you don't get a diagnosis. I think that's really tough. But I do believe that we are the patient's advocate, and it is up to us to be going back to make sure that we do get that, because there are so many, again, I'm fraudulent with Anna, but there are so many skin conditions that this could be. You know, there are pemphigoid, there's lots and lots of other conditions that would really paramount for us to get right, and it's not good enough that the patient hasn't reached that. Is it that the podiatrist hasn't had the experience of seeing that before and therefore doesn't know? So it needs to be a multidisciplinary approach, I would say, and we do need to escalate for those patients where we're faced with dealing with something that we don't know what the cause is, and actually we could provide the wrong treatment then and delay that patient's improvement. So I would be concerned with any patient that didn't achieve a diagnosis with something that wasn't a typical presentation for red legs or lymphedema.
Yeah, no, I would agree. And I think if they've not got a diagnosis yet, I think that just needs to be pursued, and, you know, maybe a referral back to dermatology if the problem's not resolved and ongoing. So I think without a diagnosis, it's difficult to sort of advise a treatment.
So I'm going to ask Becky a trick question, I think. Well, it's not really. It's one of the questions in the chat. So there is sometimes a white film over the red. Is that important?
interesting, because a film could be so many things. You know, this could be that creams or emollients or ointments that aren't washed away properly, so you get a build-up of things. That's very, very common for us to see, especially as Kat said earlier about the real greasiness around some of the ointments. They do need proper cleansing to avoid that build-up. There can also be almost a sheen or a slight lymphoria rather than a pouring of fluid, so you can get that almost like a sweat from that comes through, almost like through the pores of the skin. So you can also get that as well. We think about films in wounds as well. We think about those layers of biofilms and those sort of different layers that we get over the wound area. But in the absence of a wound, I would be thinking that this is probably a build-up of emollients that we would need to look at cleansing and using a soap substitute where possible. Of course, there are debridement aids. So there are, things like debris soft and UCS wipes and things that patients can use to provide mild agitation to the skin, or a very soft lint or cloth to help remove any buildup of products. But I think that's probably what I would suggest it might be. But again, each individual may require different assessment. And in the presence of a wound, particularly, I would want them to have thorough wound assessment and appropriate treatment if there was a film over their wound area.
Yeah, thank you, Becky. Great answer. I think the only thing I would add to it is obviously the film, or were there any skin changes, such as maybe hyperkeratosis, where you get that initial phase where it can almost look, it's not quite a film, but that buildup of keratin, which is sometimes linked to the buildup of emollients. So we have had a question about the buildup of emollients, so some of that you've addressed, but it really comes back just to good washing and cleansing and good hygiene practices to avoid that build-up. But I don't know,
and
Anna
the
and Becky, if you've
compression
anything.
I think for hyperkeratosis, the main thing for me is around getting the compression right, because once that's right, you tend to find that you're reversing that build-up process, so that actually that naturally comes away, that naturally changes. Whereas sometimes patients are vigilant with their skincare, but the hyperkeratosis persists, and so the little bit of addition with the compression can make such a difference in managing that long-term condition.
Yeah, thank you. Becky, there's a question, I think this question's come through from the chat that Cheryl's kindly passed on, from Patricia, saying, is there a level of compression in the liners? I guess that depends what type of liners, but I'm assuming they mean in the silk liners.
Yeah, so there's no compression in the silk liners. They don't have any compression at all. But yeah, if you were talking about a compression hosiery liner, it does depend, because some of them are 8 millimeters of mercury, some of them are 10, some of them are 12, up to 15. So it does definitely depend on whether we're talking about the silk garments, which don't have any compression, or whether we're talking about liners, which are used in association with another stocking over, for example, in a leg ulcer hosiery kit or under a wrap.
So I'm going to ask a question, Becky, because I think it might stir up a little bit of debate. Are the flat neck compression garments more successful in the outcome of lipodermal management? So before you answer, just like we know in simple terms, we refer to circular net, off the shelf for uniform leg. Flat net or bespoke made to measure thicker garments made in a flat piece, usually for legs that will have changes or skin folds. However, I know that I've made a change in my clinical practice because the flat net offers more stiffness that perhaps we might need in lipodermal in some cases. But there's a variation cost comes into it as well, comfort, cosmesis. Just wondered if we could, So I don't know if it's a yes or a no answer, but I'd be curious to see you and Anna's sort of thoughts on this.
So from my perspective, I would say that there's no one style of garment that's right for each patient. So I don't think you can say this condition requires this garment, because as nice as that would be, we're dealing with individuals, and we need to take into account that lipodermatous sclerosis, particularly in the early onset, as I mentioned in the presentation, can be very painful. So, you know, actually you're looking for something that's tolerable. Also, we talk about titration of hosiery. So in patients who are hosiery naive, sometimes it's a case of needing to build up slowly. And in red legs and certainly lipodermatous sclerosis, it's very common to hear patients say, or individuals say, I can't cope with anything resting on my legs. I don't even want to wear normal socks or tights. So actually going straight into a flat knit bespoke garment really may feel very much of a big step to start with. So I think that there are many benefits to a higher SSI, or static stiffness index, that as a clinician we might want to really get towards and get the patient into that. I think also with lipodermatous sclerosis there's a big shape component to take into account, because where you've got a bigger calf and a smaller ankle, you tend to get telescoping of a garment, so it'll fall down a lot, which means that the patient tends to not wear them. So that tends to be another problem which perpetuates their symptoms. So again, looking for a garment that's got a wide 5 centimeter grip top that will hold in place, or something like some of the flat knit garments offer silicone sewn within the stockings that will hold in place rather than the traditional banding, I think is really important. And you've got more options in a flat knit, but many circular knit garments you can have that grip top in. So I would say work with the individual, see what's going to work from them. There is no ideal. What you're looking for is to improve their symptoms of pain, reduce the redness, improve the skin condition, promote comfort, and ultimately control any edema.
Brilliant. Really good answer, Becky. So one size doesn't fit all. And we have to marry really the titration of maybe what's needed clinically and comfort as well, and engagement. Anna, would you add anything to that?
No, I think I would fully agree that it's just bespoke, and actually often just being able to get somebody with lipodermatous sclerosis into a garment is halfway there. And I think often once you've got them into something, you've got them in some compression, actually, you know, the symptoms will start to improve with the addition. So I think it's just getting them in something and gradually building that up as we're able to.
Thank you.
I'd agree. The only other thing I would add on that is
go back to one thing that came up. Sorry, Anna, carry on.
No, I was just going to say occasionally wraps might be helpful in that situation, that you're not having to drag something up the leg. So sorry, yeah, carry on, Becky, sorry.
Yeah, no, I would agree with that. And I think again, it's just about that shape in some of them with wraps. It's not an exact science. So again, it is making sure that that's right for that individual. I was just going to go back to touch on something I wanted both of your expertise around. It's really, really common in inflamed lower limb skin, different to redness that we see elsewhere. And in the presentation, we talked about people using antihistamines where they were able to, where that was appropriate, using the anti-itch products. So E45 anti-itch, you've got double pace, Flare, you've got Balneum Plus, quite a few with an antipruritic in. But I often find that when you get the compression right, again, the itching is improved, the comfort by reducing that inflammation. But I just wondered whether you guys had got any other experiences of that.
I mean, for me, it comes down to, sorry, Anna. For me, it just comes down to just really, we keep it really simple. To be honest, in clinical practice, we probably don't use anti-itch products. Very, very rarely. It is about the compression. It's just where everything is seeped into the tissues. It's the itching and the inflammation. And then, as I said earlier, it's then, for some, it's that varicose eczema, which is itching, and it may get quite, you know, it's all part of that inflammatory process. So it is getting the garments right and consistent. I think consistency is key. Sorry, Anna, we keep interrupting each other. I think we're super keen on answering.
No, I would say exactly the same. I think the key is the compression. The only other thing we've referred to dermatology in the past where we've had big problems. And again, occasionally they'll prescribe topical steroids for that as well, but we wouldn't do that routinely without advice and sort of discussing that at an MDT level.
Yeah.
So,
and also just touching on itching being a symptom that was common, I just wondered also about pain, because again, we touched on pain in the presentation, and somebody put in the chat about neuropathic pain, which again can be a significant problem for managing patients in compression, because again, that can be really difficult to get across to an individual that if you've already got pain, which gives you tingling, pins and needles, altered sensation, and a burning sensation, and then you're asking to layer up on top of that, that again can be a real concern for people to try and get a buy-in from that. So again, using appropriate analgesics, GP review for pain relief, being aware that pregabalin, gabapentin, that group of drugs that many of these patients are on, can exacerbate lower limb edema, and many red leg patients do seem to be taking these these prescription drugs, but also then looking again at that slow and gentle approach to compression, I think is really important. So rather than saying, oh, you're not suitable for compression because you've got some neuropathic pain, actually, as long as their arterial status allows, looking to build that up slowly.
Brilliant, thank you. So I think we've done nearly all the questions in the chat, with the exception, I think there was one question that wasn't in English. I couldn't. Yeah. So I think we've done all the questions. So unless there's anything else from Becky and Anna, I may just draw things to a close and thank everybody for coming along today. Just really hope the session has been useful. I think there is more work to do to raise awareness. We need to continue to do that for that to be recognised. And just to say, we've still got further exciting sessions over the next couple of days. So tomorrow, it's all about the garments. We've got 2 sessions on tomorrow, prescribing garments for lymphedema, getting it right first time. And prescribing a garment is only the start, how to help patients manage their compression. And then on Friday, there's supportive patient self-management and empowerment. So there's still time to sign up or promote with colleagues. That would be appreciated. And also just to say, given that it's Lymphedema Awareness Week, we're really giving a push on encouraging people to sign up to the BLS as a friend. It's free. You can sign up and you'll be notified when key documents come out. And again, share that with colleagues. And you will get information, global emails, and kind of quarterly newsletters. And again, thank you very much. We've got, for those that are working in the professional field or have an interest in lymphedema, you don't need to be a lymph specialist or a lymph nurse. You just really, I suppose, maybe would have to have an interest in that, and you can come along and join, become a full member, come along to our annual conference, which is highly acclaimed, in October of every year. So it'll be, I can't remember exactly, is it the 2nd and 3rd this year, I think, of October in Chester Racecourse, if you're interested. But thank you everyone for joining today. And I'm absolutely blown away of all the different countries we've had join us way outside the UK, and feeling very envious. Do I want to go to Croatia or the Netherlands or Australia? So it was wonderful to have had an international reach today. And of course, Ireland, my homeland as well. So thank you, everybody, and take care. Thank you. Thanks, Becky. Thanks, Anna.
Thank you. Thanks, Becky. Thanks, Kat.
Thank you very much. Bye-bye, everyone. Bye-bye.
Bye.